Now we'll introduce the theme for UCCC 2021, Hpv Vaccination course completion for First Nation adolescents. Essentially, Hpv vaccination protects against cervical cancer. We've noticed, however, that Hpv vaccination coverage for First Nation adolescents is lower than other Australian adolescents, potentially failing to reduce the incidence and mortality due to cervical cancer. Your task is to design an intervention to increase Hpv vaccination 2-dose course completion amongst First Nation adolescents. You will have a budget of $3 million to implement your proposed solution over a timeframe of up to 5 years. To give you a well-rounded overview of this topic, we have invited experts in the field to present tonight. Before we begin, we would appreciate your feedback on Info Night 2021. So if you could please fill out this evaluation survey during the event, that would be much appreciated. Everyone who completes it will be entered into a raffle for a $20 Uber Eats voucher to be drawn at the end of tonight.
Okay, let's get started with our first presentation. So I'd like to proudly present our first speaker, Professor Ian Frazer, one of the co-inventors of the technology enabling the Hpv vaccine. He's also a trained clinical immunologist, so his career as an accomplished clinician scientist has led to his roles as the inaugural president of the Australian Academy of Health and Medical Sciences, member of the Australian National Science and Technology Council, and many other research groups. Unfortunately, he was unable to attend tonight, but he has very, very kindly pre-recorded a video for us to watch.
Sorry, team, I don't think we're getting any audio from the video.
Thank you for mentioning that. Patient, maybe if you're unmuted, we can hear the audio. Maybe just play it and see.
Okay, let's give this a go.
Most of the pink countries on the map, we have screening program.
Is that effective?
Yeah, all good.
Perfect. Okay, second take.
Hi, I'm Ian Fraser, and I'm going to talk with you today about the development of the vaccines to help prevent cervical cancer. Cervical cancer is a major global problem with over 330,000 deaths every year. Most of those deaths are in the countries but in dark red on the map in the developing world. In the developed world, most of the pink countries on the map, we have screening programs to help prevent cervical cancer. These screening programs were developed as a result of the work of George Papanicolaou, a pathologist in New York who in the 1920s was interested in trying to detect cervical cancer early. He worked out that you could take samples of cells from the neck of the womb where the cervical cancer develops, and they might either be normal, as shown on the left-hand side in the picture, or abnormal and precancerous, as shown on the right-hand side of the picture at the bottom. So he had this test, if you like, to help early detection of cervical cancer. He published that in 1943, and really nothing very much happened as a result of that in terms of prevention of cervical cancer until national screening programs for abnormal cells in the cervix of the womb were introduced, as shown for Great Britain in 1987 here. And when the coverage for screening went up from 10 to 20% up to 80 to 90%, so the incidence of invasive cervical cancer gradually diminished. So this was a practical means of preventing cervical cancer, but of course it didn't give any clues as to why cervical cancer occurred, and it didn't therefore give any means of preventing it directly. People became very interested in why cervical cancer developed in the 1960s when it was realized that there was a direct connection between the number of sexual partners that you had and your risk of getting cervical cancer, so that the patients who were more likely to have multiple sexual partners than control group patients who didn't develop cervical cancer. And this suggested that there perhaps was an infectious agent that might be responsible for the development of cervical cancer, although of course it gave no clues as to what that infectious agent might be. epidemiology does throw up unusual results from time to time. In the same study that was reported as showing that multiple sexual partners increased your risk of cervical cancer, also showed that you were more likely to get cervical cancer if you first had sexual intercourse on the ground as opposed to in a bed or a hotel room. So that you have to be careful how you interpret the data that comes out of epidemiological studies. But there were several other ones that showed that perhaps an infectious agent might be responsible, and a lot of speculation as to what that might be, because there are multiple infectious agents that are found in the genital tract. Harold Zerhausen was the first to suggest that perhaps papillomavirus might be responsible as the infectious agent that caused cervical cancer. He was a pathologist, and he worked on papillomaviruses and cancer in animal models, particularly in rabbits, and demonstrated that papillomaviruses in rabbits and dogs could produce skin cancers. He also knew that papillomaviruses produce genital warts in humans, and he knew that genital warts, of course, were in the same place pretty much as where cervical cancer developed. And he speculated that perhaps papillomaviruses might be responsible for the development of cervical cancer. He, of course, didn't actually prove that, but what he did do was he got his research group to show that if you looked in cervical cancers, you could find the genetic information of papillomaviruses. The picture on the right under Zerhausen's photograph shows that a number of little black lines, each of those black lines represents a cervical cancer which contained genetic information from papillomaviruses. He, of course, didn't know at that time that there were very many different papillomaviruses, but he did have samples of one or two papillomaviruses which he thought might be responsible for cervical cancer. And his studies confirmed at least that there was papillomavirus in a cervical cancer. Of course, it doesn't prove that the virus was actually responsible for the cervical cancer, but it was a start. What happened after his report of this was that very many groups did experiments where they put genetic information from papillomavirus into normal cells and showed that those normal cells could become cancerous or precancerous if you introduced the papillomavirus genetic information. And over the course of the next 5 or 6 years, it became generally accepted that there was a fairly high probability that papillomaviruses might initiate cervical cancer. That led to the possibility of developing treatments. Now, prior to the knowledge that papillomavirus was responsible for cervical cancer, the only treatments that were available were destructive, as suggested by this mechanism of getting rid of warts from your finger, which are also papillomavirus related. I mean, that's not a recommended treatment for finger warts, although destruction was always available for the cervix. But interestingly, quite a number of people on Facebook recommended this as an interesting observation. Prevention of the infection seems more sensible than treatment. That became possible because of Harold Zerhausen's discovery that papillomaviruses were likely to be causal for cervical cancer. However, what he did not know, and what we now know, is that first of all, there are very many different papillomaviruses, at last count over 200, and that the infection with these papillomaviruses in the cervix is very common. So the slide in the middle here shows that if you take a group of college students at time 0, and then at that time they don't have high-risk papillomavirus infection, particularly Hpv 16, which is the one that's most commonly associated with cervical cancer, and then you just follow these individuals over the next 3 years, what happens over that time is that more than half of these college students will acquire an infection with a high-risk human papillomavirus, Hpv 16. They don't know they've got it, and fortunately for us, the vast majority of these infections heal themselves. So this second slide on the right-hand side shows that if you take at time 0, 100% of the population that have papillomavirus infection in their cervix, by 5 years, only 1% of them are still infected. The other 99% have cured themselves of the infection, mostly without even knowing they've had it. So So we now know that there are multiple high-risk human papillomaviruses. 2 of them, type 16 and type 18, are most commonly associated with cervical cancer, and about 80% of cervical cancers will have one or other of these viruses. But there are several other rarer types, about 9 that we now recognize commonly associated with cervical cancer. And if you put all of these types together, they are responsible for 100% of cervical cancer for practical purposes. Again, most of these infections resolve spontaneously with time, but about 2% will progress to cancer over a long period of time. 15 years is median. Some people will have these viruses all their life and never develop cervical cancer. But interestingly, you can detect pre-cancer, the sort of abnormal cells that George Papanicolaou was describing in the cervix in the 1920s. You can detect pre-cancer cells as early as 1 to 2 years after infection. And that's been the basis of screening for papillomavirus-associated cervical cancer risk, because we can detect these pre-cancer cells early and treat before a cancer develops. This also tells us a little bit about whether it's possible to do a trial to find out whether you can prevent cervical cancer by preventing papillomavirus infection, because obviously if you had to wait 15 to 30 years to find out if your prevention of the infection was able to prevent the cancer, that it would not be feasible to actually do the trials necessary to prove that a vaccine was effective. But if you can look at 1 to 2 years and find that your vaccine has worked, then that becomes a feasible study. So Jan Zhu was my colleague in developing the HPV vaccines. He is shown in Westlake in China in the late 1980s when I went to visit him there. He and I met up in Cambridge in 1990. And we were both interested in papillomavirus infection and, more importantly, in working out how to work with this virus in the lab, because this is a virus which you can't actually grow in the lab. So he and I wanted to build a papillomavirus in the laboratory. And that was basically what we set out to do. So we used the then new technologies of recombinant DNA to make these things called virus-like particles, which are shown here. And these virus-like particles look like the virus. They look like the footballs next to Harold Zerhausen's picture, but they're empty. They're hollow. They don't have any genetic information inside them, and therefore they're not infectious. But to the immune system, they look like the real virus, and therefore, if we use these as the basis of a vaccine, it can be used to make an immune response that can prevent the infection with the real virus. And that was basically what we did. We took a material from a lesion in the cervix, this sort of nice white stripy lines. Here is actually a bit of first cervical skin that's infected with papillomavirus, cloned out the virus, took out the gene for the capsid protein, the L1 gene so-called, which makes the shell of the virus, put that into an expression system in a mammalian cell. That was important because it only worked if you put it into a mammalian cell using an expression system that worked in mammalian cells. And if you overexpress this so-called L1 protein in these cells, then you ended up with these virus-like particles being produced. They made themselves, if you like, so long as you put the right genetic information. And these virus-like particles, when purified, became the basis of the vaccines that we now use to prevent HPV infection. They have to be adjuvanted with alum, which makes the immune system work better. And this is me giving the first vaccine in Australia to the daughter of one of my laboratory colleagues back in 2006. Note that that was 15 years after we came up with the technology to make these virus-like particles. And in between, a very large number of clinical trials were done to show that these virus-like particles as a vaccine could help prevent the infection that caused cervical cancer. We took a patent out on this technology because we realized that no company was going to invest in the 15 years necessary to get from the virus-like particles to the clinical product unless they had some protection for the intellectual property. And so that we were able to patent this technology because of the some novel steps that we had to take in order to get the whole system to work, particularly the choice of cells that we used to make the particles in, the choice of where we expressed the gene that was responsible for the production of the virus-like particles, and the cloning of the genetic information from a clinical lesion, not from a cancer, because the cancer derived material always had mistakes in it. That virus-like particle technology used back in 1990 to make the first virus-like particles for papillomavirus is now more widely used for developing other vaccine technologies, and this shows the number of papers and research production shown over the course of the last 15 years using the virus-like particle technology to make potential vaccines, including, for example, vaccines against COVID. The achievement of the virus-like particle vaccines was, of course, done with industry because we couldn't do it ourselves. And so I particularly note that Ed Skolnick and Catherine Jansen at Merck were the ones that put all the work into proving in industrial scale that it was possible to make vaccines using this virus-like particle technology. We now know that these vaccines are effective, they produce neutralizing antibody, they give greater than 5 years protection against infection, and they turn out to be perfectly safe. So the challenge going forward is to make sure that these vaccines are widely used. And one of the problems with that is that we have to give these vaccines to young people to prevent them getting the infection before they become sexually active. So we have to immunize them when they're young, before the age of 12, ideally. We have to make sure we can get to the girls. So we generally recommend that vaccine programs are delivered through schools. We started off by using 3 vaccine doses to give protection. We now recognize that 2 is definitely sufficient to protect. And it might very well be that it turns out that 1 single dose of vaccine given to a girl would be able to protect them lifelong. If that were the case, obviously, it's much easier to develop a program for delivering the vaccines on a global basis. The vaccines that originally were available only protected against 2 HPV types, 16 and 18, which together were responsible for about 80% of cervical cancer, but we now have vaccines with 9 different papillomaviruses in them, and they will protect about 95% of cervical cancers. The cervical cancer is a disease of girls, but we actually choose to immunize girls and boys for 3 good reasons. 1, boys also get cancers caused by papillomavirus infection, particularly oropharyngeal, but also anal cancers. 2, if you immunize the boys, it protects the girls because if the boys are immune, they can't get the infection. If they can't get the infection, they can't pass it on to girls. Conversely, if you immunize girls, they can't pass it on to boys. And the third reason is because in many parts of the world, if you have a gender-specific vaccine, everybody assumes that there is some plan which isn't to do with your health, that's being followed through by giving the vaccine to one particular gender. And particularly in the developing world, that has proven to be quite a challenge. So it's much easier just to say this is a vaccine for everybody because it's necessary to protect everybody against the infection. So it may well be that for a global efficient protection against cervical cancer, what we should be doing is mass immunization across the planet with a single dose of vaccine to all 12-year-olds, which would probably be the most cost-effective way of giving cervical cancer protection. But just to put the whole thing in perspective for you, I think it's important to realize that this is a very serious infection, and while we accept the use of most vaccines to protect serious infections, there's still a challenge in getting the cervical cancer vaccine out there. So I thought I would just compare for you the protection that you get from polio with the protection you get from HPV. Polio used to be an extremely common infection. The lifetime chance of catching the poliovirus infection prior to there being a polio vaccine was about 50%, just as it is with HPVs. Again, it's a 50% chance you'll get the virus if you've not been vaccinated. Lifetime risk of getting paralytic polio, if you get the infection, is 1%, and the lifetime risk of death is about 0.1%. 1 in 1,000 people that get polio will die of it. For papillomavirus, 2% of people will develop a serious disease, cervical cancer, and 0.8%, maybe about 1% of people will go on to get cervical cancer. In the developing world, particularly, a death rate of 1% from cervical cancer is not unheard of. So these diseases are approximately equally nasty. And interestingly, in the year before polio virus vaccine became available in the United States, 3,100 people died of polio and 21,000 were left with disabling paralysis. So when you compare that with papillomavirus in the year before the papillomavirus vaccine became available in the United States in 2005, then 3,900 women died of cervical cancer and 12,000 developed cervical cancer and were treated for it. And that's in a country where there was already a screening program. Papa Nicolau had introduced nearly 100 years previously that was quite able to prevent cervical cancer if it was used. But of course, the screening program was not effectively used in many countries because women weren't particularly keen on it, and it required a lot of effort in order to get the screening program to work. So really, polio and papillomavirus are equally serious diseases, and the efficacy of the vaccines, well, it's actually somewhat better for the papillomavirus vaccines. They are more likely to be able to prevent cervical cancer than the polio vaccine is to prevent polio. And the safety of both vaccines is excellent, but in fact, again, papillomavirus wins out because very occasionally the poliovirus vaccine can cause paralytic polio, especially if they use the live attenuated poliovirus vaccines that are used widespreadly in the developing world. So that we have basically a story which says we should certainly be immunizing to prevent cervical cancer with at least the same enthusiasm as we immunize to prevent polio on a global basis. And with that, I'll stop and thank you very much for your attention.
I'm sure you found Professor Ian Fraser's presentation helpful in developing your understanding of cervical cancer prevention and HPV vaccination. Next, we'll hear from Associate Professor Julia Brotherton, Associate Professor Lisa Walt, and Dr. Tamara Butler. So Associate Professor Julia is a public health physician and medical director of VCS Population Health. For over 15 years, Julia has been involved in research and policy development, informing the implementation and evaluation of HPV vaccination programs in Australia. She has been a lead investigator in Australian research, which has demonstrated the world's first evidence of dramatic declines in both HPV infections and pre-cancerous cervical lesions in young women post-vaccination.
Associate Professor Lisa is one of Australia's leading figures on cervical cancer control in Aboriginal and Torres Strait Islander women. She is the principal investigator on an ARC Discovery Indigenous grant focused on understanding the modifiable factors that influence uptake and completion of HPV vaccination for Aboriginal and Torres Strait Islander adolescents.
Dr. Tamara is an Undambi woman and an early career researcher. She was awarded her PhD in social psychology by the University of Queensland in 2017. She is a mixed methods researcher, and her interests include improving cancer outcomes for Aboriginal and Torres Strait Islander people by understanding factors involved in participation in screening and prevention programs. Now, I'd like to give the floor to Julia, Tamara, and Lisa.
Thank you so much. My name's Julia Brotherton, and I'd like to start by acknowledging that I'm calling in from Wurundjeri country here in Melbourne. And I would like to pay my respects to elders past, present and emerging, and acknowledge Aboriginal and Torres Strait Islander people on this call today. It's really wonderful that this is the topic for this year, and it's certainly an area that I'm very passionate about as a public health physician. So I'm going to take you through, I guess, many of the issues that Ian has already explained and raised with you around HPV vaccine and its role in cervical cancer prevention. But I want to put the role of HPV vaccination more into a global context about the contribution that we believe it will make in the long term to what is now a global strategy to eventually result in the elimination of cervical cancer. So incredibly exciting times, and I think making sure that we give that the most equitable reach we can, including to our Aboriginal and Torres Strait Islander peoples here in Australia, is absolutely fundamental and critical. So without further ado, can I have the next slide, please? All right, so you've heard about this from Ian already, the fact that HPV infection is unbelievably common. almost all of us will have it at some point, and most of the time it clears up by itself. But as you can see in this graphic, once the HPV has entered into the cells, it can it usually causes a short-term infection, produces infectious virions, and then will resolve itself over 1 to 2 years in total. It is the small number of people, probably about 10% of women, who are unable to clear this virus, who are then at risk of eventually developing cervical cancer. And of course, this is now the target for our vaccines. Next slide, please. This is another way of thinking about this, and let me just orient you to what this graphic is showing you. So what we can see at the top there is a microscopic image of what cervical cells look like if you collect them on a pap test. And you saw similar slides from Ian as well. And the images in the middle is what you would see if you inserted a speculum and looked at the cervix. So on the left there, you can see a perfectly normal, healthy cervix with no infection. Moving from left to right, once we have HPV infection, you can sometimes see signs of that, and certainly in the cells we have what we call a low-grade infection happening there. Now you can see in the arrows at the bottom, most of the time that resolves, but in some cases it can progress to what we call pre-cancerous lesions. Now certainly the majority of these will still resolve over time, and it is the minority, usually over decades, that eventually can develop into cervical cancer. Now, the reason for showing you this picture is really to drive home the point that vaccination actually allows us to block that very first arrow. So it prevents infection in the first place. It does absolutely nothing if you're already infected. So the vaccine will not help you to clear an infection, but it is amazingly effective at preventing HPV from entering your cells in the first place. And that's how it works. Obviously, in terms of control strategies, this tells us that that is the pivotal place to work. But of course, screening is trying to find those precancerous lesions so they can be treated. And of course, the other end of the spectrum is once a woman has cancer, we certainly have treatments that can be effective as long as the cancer is detected early. Next slide. In terms of how promising the vaccines are at preventing cervical cancer, Ian again has alluded to this already, but you can see these are the most common oncogenic or cancer-causing types of HPV in cervical cancer. So the blue bar at the top is HPV 16, which is by far the nastiest or most aggressive type. And you can see it's responsible for about 60% of cases globally. If you add in HPV 18, which is the next most oncogenic type, you'll see you're getting up to around 70%. It's probably closer to 80% in the Australian setting. And then if we add the next 5 most frequently found types, we're getting up around the 90% mark. So you can see that if we have effective vaccines that provide this broad spectrum of protection, we can certainly hope to get very close to eliminating cervical cancer caused by these types. Next slide. So again, this is another graphic, just thinking about it in a slightly different way. And this comes from the WHO Global Strategy to Accelerate the Elimination of Cervical Cancer. And I do recommend Googling this one up and having a good read. And basically this tells us that in the same way that we can think of vaccination as being preventive, screening as detecting early disease to prevent cancer, and then cancer being treatable, this looks at that over the life course. So obviously, most of us get exposed to HPV as soon as we become sexually active, and we can take primary prevention measures. So in pink there, we're really targeting secondary prevention at women in their middle years, when we would know that if there's any precancerous lesions, that's when we would be most likely to find them and prevent cancer. And then of course, in older age, where those lesions could have been present for longest, is where we're most likely to find cervical cancer developing. Next slide. When we look globally at this in real world, how many women are being impacted, you'll see, I hope, that this is actually a disease of inequity. So you will see that in sub-Saharan Africa, absolutely horrific rates of this disease. And this is despite the fact that we have had Pap testing available for over 50 years and known that it can work. It's just not scalable in many settings. I also really want to highlight to you our northern neighbours. If you have a look at Papua New Guinea, they have very, very high rates of disease just across the border from us. So again, showing that the complexity and the health systems required to implement cervical screening are very challenging. Next slide, please. Here we're looking very similarly, but at the mortality rates. And again, it's the same story of inequity, and you'll see Australia's doing quite well off the back of our long-standing cervical cancer prevention program. Next slide. So let's talk a little bit about the future and where we hope we're going in our journey towards reduction of the cervical cancer burden globally. And this is a conceptual framework that comes from detailed modelling that has been done and looks at what we could possibly achieve with combinations of screening and vaccination. And you'll see that the top line there, if we maintain our current rate of vaccination and screening globally, we're really not going to make any progress in terms of cervical cancer cases on a global perspective. It's just not enough. If we scale up vaccination massively and try and reach every girl, you can see we can have a fantastic impact, but it's going to take a long time to start bending that curve. And obviously, this means that many women will die of cervical cancer before we reach that end game. You'll notice the green line, and this is the projected combination of scaling up cervical screening intensively and vaccination at the same time. And that's what we're going to talk about next. So next slide, please. So these are the targets that have been determined by WHO and announced in November last year as global targets to accelerate the elimination of cervical cancer, where elimination means every country is to reach a target of less than 4 cases per 100,000 women, making it a very rare disease. It's been estimated through these models that in order to achieve this by 2030, we need to scale up to the extent that 90% of girls are fully vaccinated with HPV vaccine, 70% of women are screened twice in middle age using an HPV test, and 90% of women around the world receive treatment and care for cervical disease should they need it. These are certainly ambitious targets, but they do provide a way forward for us all. Next slide. So this is going back to the similar line that we saw before, but this time showing that if we get to those targets, we can reach that elimination threshold. And it's been projected that every country can reach this. And this includes those countries that were the most impacted, who have the highest current burden, which is why the strategy is really, really exciting. Next slide. In fact, if we can scale up and achieve those targets, it will result in over 62 million cervical cancer deaths averted over the next 100 years, which I think is incredibly exciting and motivating for all of us. But how are we going? Next slide, please. This is data that comes straight out of that global strategy report, and just really makes the point, as I said, this is a disease of inequity, and our prevention strategies as implemented to date are currently highly inequitable. So the bar graph you can see there shows how many countries in different income bands currently have a cervical cancer screening program. And clearly, if you're in a high income country, you're far more likely to have access to screening than if you're in a low income country. Similarly, we know that the vast majority of HPV vaccines delivered to date have been given to girls in high income countries, and less than a quarter of low income countries have actually introduced the vaccine. You can also see here that only a third of low-income countries have got pathology services, surgery, chemotherapy, and radiotherapy available to women who develop cervical cancer. So the burden and suffering from this disease globally is currently massive. Next slide. Moving back to HPV vaccines, in fact, 60% of cervical cancer cases occur in countries that have not yet introduced HPV vaccination. Now, this is a little hard to see, this graphic, but basically the bigger the square, the bigger the country, the larger the population. And you can see those giant squares there. India and China have massive populations, but no national HPV vaccine program yet. You'll see the standout is Brazil, that giant blue square at the right there, which has a very large population and has got very good coverage as well. And Australia is a tiny little blue square at the bottom. So we really need to get moving on getting those vaccines into national immunisation programs around the globe. Next slide. Of course, we now have the overlay of the pandemic, which unfortunately has seen global HPV vaccine coverage decreasing in 2020 for the first time. So those upper two lines there are the female coverage for 1 dose and course completion. And you can see it was trending gradually upwards, but has had a little bit of a hit, particularly for course completion, due to obviously disruptions from the pandemic affecting abilities of services, particularly school-based vaccination services, to reach goals. The bottom green lines are those countries that have male vaccination programs. And you heard Professor Fraser say that if you can do that, it can be a very effective strategy. And we're very lucky in Australia that we do also vaccinate males as well. However, globally, of course, the priority is getting vaccine into girls' arms. Next slide. So I'm just going to finish off by giving a quick summary of our own program before I hand over to Lisa and Tamara. I get asked this a lot by global colleagues. How is it that Australia, who introduced the world's first large-scale HPV vaccine program, vaccinating all females aged 12 to 26 free of charge in 2007 to 2009? And these are the reasons that I tell them. I think we have a very long history of successful vaccination programs, including in schools. I don't think we can underestimate the impact of Ian's work. You see the lovely picture and caption of him at the time, described as God's gift to women. He was, you may or may not be aware, Australian of the Year in 2006, the year before the vaccine program launched. And I think there was a lot of media attention and community demand for this Australian vaccine. And we, of course, have robust public health infrastructure and expertise that goes all the way along the pathway about supporting safe, effective vaccination programs. Next slide. So, as I said, we started off with a very big bang, providing all females aged 12 to 26 years the HPV vaccine between 2007 and 2009. And you'll see on the left there, the nice pink image of the mother and the daughter. We talked about the cervical cancer vaccine at that time in the female-only program. In 2013, we introduced the vaccination program for boys, and that's the middle image there. We've gone gender neutral here with both sex vaccination, and we're now talking about HPV-related cancers. And then in 2018, we introduced the non-valent vaccine, so the vaccine that covers more of the types now in just 2 doses, which we now know is effective as long as you give the first dose below the age of 15 years. So that's where we're at in terms of delivery. We're using a routine school-based program, but you can actually catch up to the age of 19 through primary care. And my last slide, I want to leave you with this because this is, I think, bringing together some of the strands that I've already talked about, which is that the global vision is to eliminate cervical cancer. And this is modelling from Karen Canfell's modelling group at the New South Wales Cancer Council, which actually shows the incidence and mortality. Incidence is on the top and mortality is on the bottom of cervical cancer over time. And you'll see that little blip in incidence at the top. That is due to our new HPV-based screening program. So that began at the end of 2017 and is bringing forward the diagnosis of cervical, very early cervical cancers in Australia because it is far better than the Pap test we used to use. And you will see a projected decline over the next decade, in fact projected to get below that elimination threshold, hopefully by about 2030. So this is really, really exciting times. But what we want to talk about now is making sure that there aren't important population groups in Australia who are left behind. We want elimination to be for everybody, this modelling presents the average for all Australians, but we already know there are some groups in whom we're not reaching as well with the vaccination and who have lower screening rates. There are many vulnerable groups still left, and we really want to focus our attention to making sure elimination is for everybody. And now I'm going to hand over to Lisa.
Thanks, Julia. And I am relieved that your internet held out for your presentation, because I would not have done such a good job. So hi, everyone. It's so nice to be here. I'm zooming in from Ngunnawal Ngambri country here in Canberra. And I have the pleasure of working very closely with Julia and Tamara. My family's from Mabiag Island, which is a small island in the western part of the Torres Strait. And I was born and raised on Walgarookaba Bindal country up in North Queensland. And now I have the pleasure of working really on such an exciting area of public health in cervical cancer elimination, and specifically thinking around elimination for Aboriginal and Torres Strait Islander people. So I guess my job is really to focus in now on HPV and where that fits in with elimination. And I'm hoping that some of the reiteration of some of the points is helpful, because I know that we think about this stuff all day, but this might be a new thing for you all to think about. So if we can go to the next slide, Tamara. Great. So Julia's just done a great job of talking about elimination in Australia. We know that we have been a global leader in so many ways, of course, notwithstanding both Professor Fraser's contribution, but I also just want to acknowledge Julia's contribution to this space has been incredible. And we really lead the world in how low our cervical cancer incidence and mortality rates are. So you can see our incidence sits at around, at a population level, at about 6.3 per 100,000. So it's requiring about a 37% reduction in order to reach the elimination threshold, which the World Health Organization has set at about 4 per 100,000. But I should note that a rare cancer threshold is classed at 6 per 100,000. So we're very close to 6 per 100,000, and we're getting closer and closer to that elimination threshold. We have very low rates of mortality, 1.4 per 100,000. But of course, we know, given how preventable cervical cancer, no person should die from this disease here or elsewhere. And as Julia has said, we are really could see elimination here in Australia as close as 2028, which is obviously very exciting. The key issue now is to think about equity. So if we look at this slide, this is age standardized cervical cancer incidence, 2020 data from Globocan, and really it's just a different way of looking at the maps that you've seen. And so you'll see that the sort of sub-Saharan Africa have very, really quite high rates and unacceptable high rates of cervical cancer incidence. And all the way down the end, the sort of ranked, I guess, is Australia and New Zealand, very low rates of cervical cancer incidence. But it really masks that within country inequity, because we're just looking at the whole population. And so when you have populations like Aboriginal and Torres Strait Islander people who make up only about 3.3% of the population, you really can't see those differences in the data when you're just looking at the whole population. So as I said, it really masks those inequities. If we focus now just on Aboriginal and Torres Strait Islander women, we know that they're experiencing a much greater burden of cervical cancer compared to non-Indigenous women. So incidence is about 2 times higher, and mortality is more than 3 times higher. It kind of swings around close to 4 and then a little bit back down, but definitely over 3 times higher. And it's interesting, I guess, to note that this is a very similar situation we see with other Indigenous populations in high-income colonised countries as well. And so a lot of this is around, I guess, some data issues, so not being able to fully see the picture and where to direct resources, but definitely that there has not been the same access to these population programs as we would like. So if we just go to the next slide, I guess this kind of gives a more visual representation of the slide we've just spoken about. So again, we can see here exactly the same graph with all the countries or regions ranked around incidence. And you see right down the bottom, Australia and New Zealand, very low rates of cervical cancer incidence. But if we map where Indigenous Australians incidence rates are, you can see it's much more comparable to the sort of low and middle income countries, more so comparable to them actually than to non-Indigenous population here in Australia. So we can go to the next. Yeah, and this just shows mortality. So exactly the same story, I suppose, except we're just looking at mortality. So again, much higher rates of mortality rates more comparable to sort of middle income countries than with Australia, Australia, non-Indigenous women. So we can go on. Okay, so I guess one of the common questions we'll probably all get asked is around, well, is Hpv infection different among Indigenous women? And I guess it's a good question to ask, given that they have high rates of cervical cancer, but the short answer is no. So before the vaccination program was introduced, work done by Susan Garland and Julia was able to demonstrate that prevalence of HPV genotypes of 16 and 18, the ones that we know cause the majority of cervical cancer, was similar between Indigenous and non-Indigenous women. There's a little bit of difference between some other high risk, other genotypes of HPV in the older years, but we also knew in that analysis we couldn't adjust for higher smoking rates and some other things that we would like to adjust for. So a little bit of difference, but not enough to explain, I guess, the incidence difference. Really positive is that post-vaccination, so after the introduction of the vaccination program came in, we've seen really similar declines between Indigenous and non-Indigenous women in both the prevalence of HPV 16 and 18, and also in genital warts, which is excellent. Sorry, Tamara, you can go to the next slide. So if we think back to those WHO elimination targets that Julia went through, around the 90% HPV vaccination completion for girls aged 15 years. And this is a report done that I would highly recommend everyone go and have a read, that Julia, myself and others worked on, which is the NHMRC Centre for Research Excellence in Cervical Cancer Control. It's essentially the elimination progress report where Australia currently is up to date. And it really is an excellent report because it for me, it highlights the areas that we need to work on. So this is the target for vaccine completion. And you can see here that Indigenous and non-Indigenous on the left-hand side of the graph, this is by boys and girls, males and females. You can see that for both Indigenous females, Indigenous males, vaccine completion is much lower than for non-Indigenous males and females. You can see, depending on where you live, that also changes, but that just wanted to demonstrate there for Indigenous and non-Indigenous that HPV completion is lower for Indigenous males and females. So the next slide really looks at completion, so vaccine completion over time, and you can see what's really positive is that it's increasing over the years. So there's still a gap, and the gap seems to be persisting, but that we are improving, I guess, on the proportion of the cohorts that are completing their HPV vaccination program. So the next slide is really initiation. So that's having at least one dose. You can see that this is sort of, the gap's much slimmer here for between Indigenous and non-Indigenous adolescents. So there's still a slight difference between males and females, and a slight difference between Indigenous females and non-Indigenous females and males. The same thing, but it's getting much better. And so, if we look to one dose, this is a really promising picture, but of course we need to keep making sure that it's equitable, and that all, the current recommendation is that it's 2 doses, and so we need to make sure that that second dose is getting in the arms of Aboriginal and Torres Strait Islander adolescents. And I guess just this is another slide to show some differences in the data, because that data that we've just looked at is a sort of a national picture. This is data taken from the Queensland School Immunisation Program for 2019. There hasn't been one yet released for 2020, but I imagine it would have been had some impacts from COVID. And you can really see here, this is hospital and health service. So depending on where you live in Queensland, you can see, I guess, the difference between dose 1 uptake and dose 2 uptake. So dose 2 is in the yellow, dose 1 in the green. And just want to bring your attention to the Torres and Cape region. So the Torres and Cape region has a high proportion of Aboriginal and Torres Strait Islander adolescents. And you can see there that dose 1 is quite high, so it sits around 80%, but dose 2 drops off to less than 40%. So you can see there's like major differences depending on hospital and health service. So I am going to finish up and hand over to Tamara, but I guess just to reiterate and pause at this moment, it's just to say that we know that vaccines are obviously a critical and important tool to elimination. And I guess our focus now here in Australia is to really kind of hone in on an equitable delivery, of course, being mindful of the sort of rapid changing landscapes, particularly around vaccines. And I think we can all appreciate at the moment, vaccines is a hot topic. And I think when we think about vaccines, thinking about how school-based immunisation programs can be a really equitable place, but fine-tuning that to make sure that that's equitable for all students that are attending schools. We also know that elimination is possible for Aboriginal and Torres Strait Islander communities. So this is definitely not a too hard basket, but it definitely requires, concerted efforts, resourcing, and like anything, it really does require political will. Earlier in my presentation, I talked about Australia as a whole needing about a 37% reduction to reach an elimination threshold. For Aboriginal and Torres Strait Islander communities, we need about a 68% reduction in elimination. So, a much greater effort is required to achieve that goal. And we know that vaccination is a core part of that. So I'm going to finish there and hand over to Tamara, who's going to talk a little bit more around Aboriginal and Torres Strait Islander research moving forward.
All right. Thanks, Lisa. Thank you for that, Julia and Lisa. Incredible clinical and epidemiological insights. And I guess this speaks to the power of multidisciplinary teams. I'm the social scientist, I guess, joining the team. And I think that could be something you think about for your own strategy. How can you have different teams working together to produce really effective and culturally safe solutions? So I'm Dr. Tamara Butler. I'm an Aboriginal woman. My mob is the Undambi mob from the Caloundra area of the Sunshine Coast, born and raised here in Meanjin, Brisbane, Yagara and Terrible Land. Currently, I'm a postdoctoral researcher at Menzies School of Health Research, and generally my work has been working towards elimination for Aboriginal and Torres Strait Islander women. So we just thought, given the important topic that you're working on, we'd give you a little bit of guidance around the social and cultural and historical factors that you might need to keep in mind as you're developing your proposal and your strategies. And these kinds of things will really help you to design a strategy that's culturally safe and therefore effective. So I guess in Australia, we really can't talk about health research unless we talk about colonisation. So there's a model called the 4 Cs, which talks about historical trauma, which explains how colonisation continues to affect First Nations people, and in this particular context, particularly health. So the first principle is that colonial injury occurred to Indigenous people by European settlers. And in the case of Australia, this was Captain Cook invading in 1788. And this was characterised by disease, dispossession of land and resources, direct conflict, massacres, wars. I'm sure you're all aware of the terrible impact that particular event in history had on First Nations people across Australia. The second principle is around the collective experience of that colonisation, and that the impacts of that colonialism was felt across entire communities, entire identities being impacted, altered and destroyed, which is, as you can understand, that would totally just completely undermine all that powerful history and law and culture and spirit that people had been building over 65,000 years. The third principle is around the fact that it's a cumulative effect, that these injuries kind of build up and snowball over time. And they've been perpetuated over time as well through not only just colonisation, but also the adverse government policies and practices that were put in place. And in law, in some cases, to deliberately subjugate and marginalise Aboriginal and Torres Strait Islander people. And the fourth principle there is about it being a cross-generational impact. You might have heard the term intergenerational trauma, meaning that the effects of these injuries are passed down from one generation to another, because they can have that quite undermining effect on very core parts of a person's being and a community's being and how they know how to be in their identity. And often until a process of deliberate healing and reconciliation occurs. So you could potentially add another C there, and that it's a contemporary thing as well. So while colonisation happened in the past, these factors continue to affect modern day Aboriginal and Torres Strait Islander people. And it's in this context that health disparities such as poorer cancer outcomes, like with cervical cancer, can occur. So it continues to shape the health landscape. It's something we need to keep front of mind as we move into a health research and health promotion space for the benefit of First Nations people. What this means is that it's really important that this sort of research and strategy and interventions needs to be empowering, and First Nations people need to be put in the power seat, or put in control of the research and ensuring it's done in the ways that are beneficial to our communities. So I guess the important thing there about colonisation is that we continue, we survive, we thrive. Okay, so we're still here, still strong, 65,000 years later, after culture and identity being around for 65,000 years. So I guess what are some of the things that we can draw on from that strength of culture that's been around for so long, that we can draw on to develop a really strong and culturally safe strategy? So I guess to understand this, we need to talk briefly about what are some of the things for First Nations people that bring about good health and well-being. So understandings of health and well-being tend to differ. They're culturally bound concepts. What this means is they differ between culture to culture. So in Australia, in our biomedical kind of system, we have a quite largely Western biomedical approach. And this is criticised for being quite clinical, quite disease-focused, quite focused on sort of ill health and focused on the individual only. So it might be an individual's ill health rather than understanding the kind of social context that that person sits within. So for many Aboriginal and Torres Strait Islander people, it's quite a different picture. And so this is a really recently developed model that shows well-being from the perspective of Aboriginal and Torres Strait Islander people. So it's called the fabric of well-being. Now we could spend a while looking at all the details of this model, but for the purposes of your strategy, I'll just draw out a couple of really important things that might help you to think about how you can make your strategy culturally safe and effective and relevant. So you'll notice the domains down the side. So things like holistic health, purpose and control, dignity and respect. These things are interwoven with these domains across the top, which are family, community, and culture. So what this really means is that well-being for Aboriginal and Torres Strait Islander people means the strength of this connection. So well-being can be understood as the strength of the connection between multiple different parts of life. So this means that health doesn't sit kind of siloed on its own on the side. It's very much interwoven with other parts of life. So you can see that if there's an impact on health, it kind of spreads to other impacts, other domains of life. The second thing I'd point out is that it's a very collectivist understanding of well-being. So in contrast to that kind of individualistic understanding of health and well-being we talked about from a Western biomedical kind of point of view. The domains on the left side are interwoven with aspects of family, community, and culture. So if you ask someone how they're doing, how they're feeling, what they're thinking about is their connections to family, community, and culture. So they're thinking about, well, if my family's well, yeah, I'm well, I'm doing well. So what this really means for your potential strategies is you can think about the things that keep First Nations people well. So things like family, community, and culture. And these could be things that you could implement into your strategy that help support whatever intervention that you put in place. And it could mean that you focus more on those sort of community and cultural and family sort of level ideas rather than focusing on individual factors or individual behaviours, although that may be a component of what you think about. So let's now talk a little bit about what we know about increasing HPV vaccination among Indigenous populations in Australia and around the world. So in Australia, there's not really been any large-scale coordinated interventions to specifically support First Nations youth to receive the HPV vaccine. As Julia and Lisa talked about, and Ian as well, we talked about the power of this school-based immunisation program. We do know that that's got the potential to be a really equitable approach and to increase access across many different population groups within Australia. We know that for the most part, it's doing okay, but we know that it can do better. So just looking at the graphs that Lisa was presenting before, coverage is, is fairly high at the moment. We can do better, but it's about making sure those 2 doses are completed. It's talking about gender equity, and it's ensuring comprehensive coverage across all areas, and that this is sustainable over time. So we can turn to international literature and other colonized countries like the USA, New Zealand and Canada, and the experiences of Indigenous populations there in those colonized countries to think about what might be working and what isn't working in terms of supporting HPV vaccination. So for example, research conducted with First Nations people in Canada found that there was really strong support for the involvement of multiple generations of family in the education and discussion of HPV vaccination with young people. So as I mentioned before, like First Nations people in Australia, there's a really strong sense of collectivism in that culture where multiple sort of levels of family and community are involved in these kinds of health discussions. And the second thing that emerged from that study was that discussions may not be limited to HPV vaccination. They might also be embedded in discussions about positive sexual health and positive relationships. So a really holistic approach to that health. So not just focusing on what the vaccine might provide, but also the context of that. In Aotearoa, New Zealand, there was a HPV vaccination program set up there. And I guess their approach was really to go in with a really strong focus on equity. So they looked around and saw, there's a chance that Maori and Pacific girls may not benefit to the same extent to other New Zealand girls in this program. So let's go in making sure that we've got those factors built into the program to make sure that they are supported. So they had an explicit focus on equity from day one, ensuring they did lots of stakeholder consultation with those communities, identified what services were already working for those communities and drawing on different characteristics of those services to ensure they were in place, and making sure they had funding to support girls and their families to engage in the program. So we know there are also a lot of barriers to accessing the HPV vaccination, and this mostly applies to Indigenous peoples in Canada, New Zealand and the USA. So these are issues such as low awareness and education and information, and also might be about the cultural relevance of that information and making sure it actually is reaching the target audience in terms of being actually culturally relevant. There's stigma, obviously, it's an STI. So obviously, puberty is awkward enough. You don't want to bring in a discussion about STIs. So there's also stuff around limited access to vaccines and the cost of the vaccination. So in some countries, it's not actually delivered at school. So we can actually see a huge benefit in contrast to Australia from delivering it at school. And the cost, it's sometimes not delivered for free. So that's a huge barrier for some. As Lisa mentioned, there's been a lot of gaps in missing and incomplete data sets. In some places, ongoing impacts of colonisation, including distrust of governments and health institutions. So for instance, in Canada, as we're seeing these horrendous discoveries of mass graves of children, if you've been raised in a context where the government has betrayed you in that way, you're going to find it really hard to support a mass public health program, such as a HPV vaccination program. You're going to need a lot of convincing to know that you can trust the government to do something for your benefit. So in that situation, you can understand how colonisation continues to have these flow-on effects today. Kids always have those concerns about the needle being painful, and you also have those usual barriers that other Australian kids might experience as well of, are they at school on the day? Did they miss out on the form? And did the parent or caregiver fill out that form as well and get it back to the school? So you can think about improving specific aspects that I've mentioned here, that's some of the common barriers. So you could think about consent forms, thinking about the particular aspects that affect Aboriginal and Torres Strait Islander people. You could maybe think about, I don't know, improving the boys' vaccination. You could think about data gaps. You could focus on looking at different coverage in remote and regional places. There's lots of different ways that you can tackle this issue, so you can really think about it quite holistically. So now we'll move on to the how of the research. And in First Nations health research, the how is just as important as the what and the why. Because I don't think if you don't do the research in the right way or develop your strategy in the right way, there's a good chance that it won't be taken up and it won't be effective. So these are some guiding principles to consider when you're designing a strategy. And most of them revolve around a decolonizing approach. So what this means is actively challenging the kind of ingrained colonial systems of knowledge creation. And that's seen some researchers go in, take knowledge from communities, take it back to their academic offices, write papers, get careers and get rich, and not return those benefits back to those communities, including the potential health benefits. So this leads to research that's really quite deficit focused and frames First Nations people as a problem to be fixed, which is not what we want. So in contrast, decolonizing methods center First Nations ways of knowing, being, and doing, and it places that identity and culture as central to the research effort, and in fact, just completely critical to actually doing it in the right way. And so this is a holistic approach, and it affects all different aspects of what you might do in your strategy. And I'll outline a couple of different things that you can do along the way. So the first one there is making sure your work is strengths-based. So it's sometimes helpful to define what it's not. So it's not a deficit discourse. So by deficit discourse, we're talking about a mode of thinking that frames First Nations people and identities in a narrative of negativity, deficiency, and failure. And if I can be kind of blunt, it's the kind of Courier Mail front news page that you might see, framing the person as the issue. It frames people as responsible for their own state of often ill health without thinking about the kind of context around that person, the socio-political determinants underpinning that person's situation. So it doesn't consider the kind of systems or structures that might be preventing that person from taking advantage of these wonderful programs that we do have in place in Australia, like this cervical screening program, like the Hpv vaccination program. So strengths-based approaches are quite different. As the name suggests, it focuses on the strengths. You move away from comparing groups for the sake of it. You're not making comparisons just to show that one group is worse off than the other. You acknowledge that you probably have that data already. You don't need to describe it again. You can take that information and go, right, what can we do about it? And how can we do that in a way that's positive? The focus on what keeps people well and healthy. So I talked a bit about that well-being model. So those are some of the things that you can think about. We know that those are the things that keep Aboriginal and Torres Strait Islander people well and keep them happy. So how can we draw on those things and implement those things in our strategy? And often you'll find the focus is on systems and social determinants of health. So moving away from those kind of individualistic interventions, though that can form a part of it, that is part of a kind of ecosystem of what you might implement. But really the issue is looking at, okay, what's the system around this and how can we better ensure that people are accessing all the benefits of these programs? So the next one there is First Nations, it's relationships and genuine community engagement. So good research is built on strong relationships with key stakeholders and leaders in the community, and this ensures that solutions can be co-designed together. And this takes time, it can't be rushed. So you need to take the time to find the right people, leave them time to consider the issue and think about whether it's actually something that they want to address themselves. So in your strategy, this might mean building in ample time for community consultation and ensuring that you've got those methods of constantly feeding back and having a dialogue about what's happening, why you're doing it, what your motivations are, and giving updates on how it's going. And importantly, at the end, making sure you're feeding back those findings and making sure that everyone in the community has part of understanding what has happened and what is going on. And doing that in a culturally safe and appropriate way. So finding out what the needs of the community are and what are their preferences for how you're going to feed the information back to them. It often involves food, it's really fun. So I would encourage you to have a think about that. First Nations leadership. So First Nations people ideally should be leading or co-leading this research effort and implementation effort. It's really that principle that I'm sure you would have heard, nothing about us without us. So you might think about how you can make sure that First Nations people are leading or co-leading the work. Also, you can think about other forms of leadership that might need to be represented at different parts of your strategy. And these are forms of leadership which sometimes aren't recognised by Western forms of knowledge creation. So First Nations leaders might be people like myself, like Lisa, who have formal training and qualifications and letters after their name, but it equally also includes people who are very much embedded in the community, who maybe don't have those formal qualifications, but know their community inside and out, are very strongly connected and can tell you exactly how you could implement solutions. They know the solutions themselves, they have that knowledge. So it might be elders in the community who have that kind of knowledge and law. It might be First Nations people working as health professionals in their community. It might be women's groups, it might be men's groups. And in this case, it might be young people themselves who know the solutions. They might have had the vaccine and can reflect back and go, yeah, this is what I think would happen or would work. So it's really important in your strategy that you think about different forms of leadership that could be engaged and lead and drive this work. And the final one there is reciprocity. So this is really about ensuring there's mutual benefit to those conducting the research or implementation in First Nations communities. So like I mentioned before, there's been a past kind of colonial tradition of going in, taking knowledge for personal gain and careers without giving back to the community or feeding that information back. So this is about ensuring that the community actually wants the research and that the benefits are channeled back in to the community. So you can think really creatively about this. So what are some different ways that you can make sure that there's mutual benefit? So this could include things like providing new resources or infrastructure, or it could be something really great and long-term and sustainable, like providing training or upskilling to community members that would hopefully lead to a long-term benefit and sense of reciprocity that everyone has gained something from the experience. So those were my key principles. And I guess thank you for your attention and good luck with your proposals.
Thank you so much, Lisa, Tamara and Julia. That knowledge was really pertinent to our case competition, and I hope it's given all of you a good base level of understanding to start building your proposals from. We understand Zoom can be tiring, so we'll have a quick 5-minute break, but be sure to join us back after that because we've got presentations from last year's winners for some tips on the competition and a chance for you to ask any questions you might have to last year's winners, Julia, Tamara and Lisa, or the UCCC team. So I'll see you in 5.
Okay, I hope that everyone's back. Finally, we are so excited to welcome back the 2020 UCCC winners who were in your very position just last year to share some pearls of wisdom.
Hi everyone, and thank you so much for inviting us back this year. My name is Krisha and I'm part of the UCC team from last year, and alongside with Gil, Aaron and Anushka. We had an incredible time during the competition last year, so feel incredibly privileged to be able to come back and share, I guess, a little bit about what we did and what was our approach last year. So I guess to get straight into it, just to give you a little bit of context, last year, the aim or the project that we were given was to design and propose an updated model of care for cancer survivors with a hypothetical budget of $5 million, which should be implemented over a 3-year timeframe. And our aim was to really address any issues which cancer survivors are facing, looking at the current model of care and what we could do differently. Similar to this year, in terms of what we were required to present on the day, we had to create a slide deck of 15 slides, create a report which sort of outlined our entire project. And following on from that, we had to give an oral presentation on the night to the audience. So I guess just to begin with, our initial approach was that obviously when you got this beautiful case report, which is really detailed and has a lot of information, it felt a little bit overwhelming because you don't really know where exactly to start. So you sort of had to take a step back, and we did a lot of background reading, trying to identify what sort of issues were faced by cancer survivors and to look at what research was already out there, and what, I guess, expert stakeholders and actual cancer survivors had to say with the matter. We then sort of went on to identifying key aspects of the issue that we felt that we were able to target. So this could, we know some teams chose a really specific topic. We decided to go something that was quite, I guess, broader, and we targeted financial, social, psychological, and medical aspects of the issue. And then basically spent a lot of time initially just trying to come up with a model for our proposal. And I think one thing which we can say from there, the thing that worked for us is after coming up with this model to really make sure that it's really structured and you have like a detailed approach or plan as to how you're actually going to work through this issue.
Awesome. Hi, everyone. I'm Arun. So just following on from what Krish was mentioning, this slide sort of captures how we tried to execute some of those strategies that Krish was mentioning. So one of the first things we did was we unified our ideas under this model or under this umbrella term of climbing out of cancer. That became not only our proposal's name, but became our team's name. So it provided a sort of something that we could pitch. It made the advertising of our proposal easier, and it provided a broad umbrella under which all of our ideas could fit. I think the second thing we did was obviously the issues we face within cancer survivorship, and same with the challenge this year, are multifactorial. There's a lot of issues there, and it's really hard to address all of them. And I don't think that's what the case challenge is about. I think it's about being able to pick out the aspects that you think are important based on evidence, and then being able to propose an idea for those. So one of the second things we did was we actually identified those key themes that we wanted to approach, in this case with medical, psychological, financial, and social, recognizing that we can't solve everything. The third thing we did, as Krish was mentioning, if you want to have a 3-point plan or a 4-part model, that's really helpful for structure. So in our case, we had a 4-part model under climbing out of cancer, and collectively those 4 things targeted the key aspects we were trying to address within cancer survivorship. So we should go to the next slide, Krish. So then in terms of the actual ideas, and I think that's the really challenging part, in terms of how do you come up with ideas which are sustainable, which are feasible, and which are innovative. I think that was one of the major challenges we faced. I think the first thing is when you're coming up with your ideas, it's really important to probably ground them in evidence. And obviously they're complicated issues, that's why we're discussing them. But I think ways you can find out what works and what's good evidence is by looking at what's happening in other countries. I think that's really helpful. Finding sort of international precedents or historical precedences for your models or for your ideas, and also ideas that are recognised or currently actively being discussed by experts and endorsed by experts can mean that you're basing your model on hard evidence. I think the second thing is around information around budget and timeline is quite important, because that demonstrates how feasible your idea is. So although it can be quite complicated to create a big model that fits under a $5 million budget, I think it's really important to spend some time with that, because when you can present your model as feasible, it sounds a lot more palatable to the audience and to the judges. I think it's really important to use modern technology. And that's where you can sort of make your proposal really innovative, and it also allows you to stand out from previous historical attempts. And lastly, I think it's important to recognise that there will be limitations and risks with your proposal. It's important to identify these and probably show how you're trying to mitigate them. So just quickly, in terms of our proposal, we integrated an app. An app was at the core of our proposal. We thought that was an innovative, modern, suitable way that fits with the modern trend of healthcare delivery. So we based a lot of our ideas through that app. And secondly, we provided quite a detailed sort of timeline with information about budgeting to show the feasibility of our proposal, and ways you can look at things like budget. For example, we looked at what was the average cost of app developments in other apps, and we based our proposal off that information. So yeah.
Hi everyone, my name is Anushka. So for preparing the presentation, it's good to make the slides easy to read and not too overwhelming with information. It is good to find unique ways to visualize your ideas. So for our presentation, we created pictures of a potential app to showcase how our idea could look one day. We also suggest splitting the workload evenly and possibly based on the strengths or interests of the team members. And ensuring there's regular updates and communication of what's happening so everyone's on the same page. Another tip is to personalize your ideas by using a case study. So we try to create a case study of a breast cancer survivor with multiple psychosocial issues and showcase how an app could practically address these. So this helps the audience see the utility and need of your ideas and makes them more sellable. And finally, just make sure you practice heaps. Next slide. So here are some useful resources we have compiled for your presentation. Next slide. So benefits of participating in the UCC. So there's multiple. So it really helped all of us get a better idea of cancer survivorship models and the unique issues that cancer survivors face. It also allowed us to build on our research, teamwork, and presentation skills. We went on to present our winning presentation at the Peter Mac executive meeting to renowned researchers in cancer survivorship, which was really exciting as well. And it's also great for CV brownie points. As final year medical students, it really did help with boosting our internship CV portfolio. So would definitely recommend getting involved. Next slide. So moving on to our internship experience. The four of us had the opportunity to have a research internship at the Peter Mac Cancer Centre in Victoria, where we're currently based near. We've also been allocated to two teams, the Australian Cancer Survivorship Centre and PC4, which is, as you can see on the slide, and we completed two separate tasks related to the topics of cancer survivorship. Again, I cannot stress how useful the internship experience has been so far, both in the experience gained as well as the direct connections you make with the experts in the field. With the COVID, the process has been virtual, but it's no way impacted how much we've learned from the experience, as the supervisors have been highly facilitating and adaptive to ensure we gain maximum benefit with our time with them. And the internship was initially meant to be only for a month in December last year. However, we have extended it and we're currently doing ongoing work for them, which is what we're really grateful for as well.
In terms of what we actually got to do at Peter Mac and PC4, we basically were allocated to two projects. The first is a systematic review, where we've been looking from the case study that we did and given that our model was surrounded around this cancer survivorship app, we actually got to conduct a systematic review looking at what sort of smartphone applications currently exist for cancer survivors. And at the moment, we've completed our data extraction and working on the write-up to actually publish our systematic review this year. So it's been great to actually be able to jump into a project that's really relevant and to, I guess, one day use the information we've collected to maybe contribute to creating a similar app in the future. Our second project has been creating a consumer and health professional fact sheet for early stage melanoma cancer survivors. The first fact sheet is now completed and ready to be published online, and we're currently working on a second one, which will be, hopefully, printed by the end of this year. So I guess it's been really exciting to actually be involved in projects that were so relevant to our model and to actually see the potential for ongoing work. And we're really hoping to continue this relationship we have with both the ACSC as well as Peter Mac. So I guess just to finish off, we wanted to see if you guys have any questions, but also say thank you once again to everyone for actually organizing this competition, because we certainly gained a lot out of it. So yeah, good luck everyone.
Thank Thanks so much, guys, for that amazing presentation. So that wraps up all of the presentations for tonight. And I guess now that we've heard from, all of our amazing guest speakers, we would like to take this chance to also open the floor up to any questions everyone may have. So we encourage you to unmute and ask your questions to any of the guest speakers today directly, but otherwise there is also the chat function. Okay, I think that means no questions then. So I might handball it back to Aisha now to just run through some of the key dates of UCCC again. Oh, hold on. No, someone in the chat. So someone has asked, thanks for the presentation. I have a question for Tamara. What are some of the drawbacks that you can think of for drawing on examples from Canada?
Oh, that's a really great question. Yeah. So because they have that colonized history that they share with us, a lot of the same experiences, we can look internationally to sort of go, okay, what's happening over there and how can we kind of draw some inspiration from that in terms of what might be useful. But yeah, you've got to remember that context is not exactly the same. There are very different issues that affect us here. And so that's something to keep in mind, that you can kind of draw from it, but also, do your good search of the literature, like those previous winners were saying. You've got to make sure that you're aware of what's happening in Australia and what the context is here on the ground, and making sure you're adapting that to say, this is feasible, it might work, but let's look at what's happening on the ground to make sure it's actually relevant to this local context as well. Lisa, I don't know if you had anything else to add to that, or Julia as well.
Yeah, I think, it's a really good question. I think we have a lot to learn from other Indigenous populations who've experienced colonisation. I think, though, we should be mindful of how different countries are, I guess, are along the kind of process of reconciliation with their Indigenous populations. And so, here in Australia, we're absolutely, we don't have a treaty. There's no recognition within the Constitution. So this is we're in a very different situation, say, as Canada, who've gone on to have a truth-telling commission, and those, so I think just having those, and like I say, in New Zealand, they have a treaty. So I think we just have to be mindful of those potential differences in terms of the healing of their histories. But I still think that there's lots to learn from, and we certainly pull on lots of things internationally from other Indigenous populations, and just think about how that might apply here and how we might tweak it for an Australian context.
Awesome, thank you both. There's another question in the chat. So I also have a question for Tamara. What are the main reasons for vaccine hesitancy amongst First Nations people?
So another good question. So the first thing I'd suggest there is maybe to reframe your thinking around vaccine hesitancy. And again, thinking about kind of the systems and structures that might support people or not to access those vaccines. So it may not be about vaccine hesitancy. It may be about that the system is just simply not being run in a way that allows people to engage with it meaningfully. They may be not getting the right information from the right sources, and they may not be rolled out in a way that is actually like culturally safe or appropriate. So yeah, I think maybe just reframing that question around, well, what are the things that we can do to better support people to actually access it if they want to? Yeah, and there's also other important things going on there. For those that are vaccine hesitant, like we were talking about earlier, that there's things around colonisation and a long history of governments betraying explicitly racist policies and laws in place. So you can understand that First Nations people in Australia potentially are not in a position to feel super trustful of the government. And hopefully you can start to understand that now that we've talked about it a little bit. So there's a trust issue there as well, about trusting these big public health programs as well, that we really need to do a lot of work to make sure that we're supporting people to make some informed decisions about that.
So I'll just add to that too. I think where people source information is really important. But I think traditionally here in Australia, with Aboriginal and Torres Strait Islander populations, I wouldn't say that we've had a lot of vaccine hesitancy in terms of other vaccines. I'm definitely not talking about COVID at the moment. And I think, you know, if you look at other vaccine programs, so if you look at under 5 vaccination rates for Aboriginal and Torres Strait Islander people, they're very good. They're often actually higher than non-Indigenous population, so pretty good at getting young kids vaccinated. It's the time to get vaccinated is a little bit longer. So I think maybe if you think about what could be some of the differences between, you know, why is it easier, or maybe not easier, but why is vaccination rates better among under 5s for Indigenous populations, and think about the differences that might apply to a school setting, I think might be really helpful to think through.
So another question has popped up. So thank you for the presentation. I have a question for last year's winners. In terms of time management, in which part of the whole process would you suggest us to spend the most time on? And how long should we expect to finish the whole thing?
I think in hindsight, we maybe were a little bit excessive. I remember that when it came to actually writing the actual proposal and the presentation, we probably met almost every single night for a couple of weeks at least, just to flesh out ideas and discuss things in our own time, then spend at least a couple of days just on the actual design of the presentation and creation of like little gadgets such as the iPhone application. And I think we practiced the entire presentation night speech at least 10 times. So it was a time-consuming process, but it was definitely worth it.
Yeah, I would agree. And I think the only other thing I can think of to add is that in terms of which part should you spend the most time on, I think for us, the most rate limiting step was how to be unique and how to come up with actual ideas. So I think it's very natural to hit a roadblock at that point and have to spend quite some time developing unique ideas, developing innovative ideas. And I think that step itself probably requires a lot of reading around. So I think your own proposal, your own idea, it probably deserves the most time because that's what you're pitching, I would say.
Yeah, I think when it came to actually writing the report, we left that till right at the end because it was almost like a synthesis of all the ideas we'd already discussed. And once the PowerPoint presentation was already done, it made it a lot simpler to put it together. So I think that's something that you could definitely leave towards right at the end because you would have had everything ready by then. So it's just a matter of typing it up together.
I would agree.
Thanks, team. All your hard work definitely, showed in your PowerPoint and in your overview report. And I just want to make a sneaky plug there as well for anyone who's, kind of feeling a bit lost about the whole case competition. We have released the guidelines and the case file document. If you hop onto our YouTube channel, there are links to previous year's information nights and finalist nights as well. And we also have a couple of workshops coming up. So we've got one next Monday on the basics of cancer, and another one on presentation skills and how to really, structure your slides so you can really maximize, the impact and how you deliver the message as well. Awesome. So if there's no other questions, I might just handball it back to Aisha now just to do a quick wrap up and just reiterate some of our key dates.
Yep. So if you've seen the case file guidelines, you'll probably be familiar with these dates. But as just mentioned, next Monday, we have our workshop on the basic biology of cancer. Wednesday, we have our workshop on slide making. And then submissions are due on Sunday, the 5th of September. Importantly, they're due at 4:59 p.m. On Thursday, the 16th of September, we'll be announcing finalists. And UCCC finalist night will be on the 23rd of September. So make sure you're all available for that.
Yep. And just before we wrap up, please also remember to fill out the evaluation survey and we'll draw the raffle right after the event and contact the winner for that. So sorry, there is a question in the chat. Where can we access the PowerPoint about the competition information? So it's not a PowerPoint, but if you hop onto our Facebook event, you'll be able to find a link to the guidelines document. Someone has asked, could we please go back to the key dates slide? So maybe we can backtrack one. And also if you go onto our website as well, you'll be able to see all the key dates with the times. Cool. All right, guys. So we hope you have all found information night very informative and now have some fresh ideas to improve First Nations adolescents HPV vaccination course completion rates. We'd like to once again thank our guest speakers for their contribution to UCCC 2021 and also our partners once again. Thanks, guys. Have a lovely evening and we look forward to seeing some of those deliverables soon.
Thanks, everyone.
See ya.
Thanks.